Well, thanks for the introduction and thanks, Jan, for inviting me. It's my first time here and I'm really enjoying the symposium of the city. So let's try to answer all these questions. It's not easy in 15 minutes. Probably it's not even easy in a few hours. So let's try to just give you some tips, trying to, as I said, answer this. This is my only conflict of interest, not companies, just colleagues, anesthesia colleagues worldwide that are helping us to do all the research that we are doing, and well, most of the evidence, most of the slides that I'm going to show you come from these hospitals, these researchers. So why is this topic important? Well, as you all know, the postoperative pulmonary complication is one of the most frequent complications in the postoperative period, with a high impact in patient outcomes. Not only the postoperative complication, but also length of stay, also increased healthcare costs, and even mortality. There are many papers showing us that a patient that develops postoperative pulmonary complication has an increased risk of mortality. So we need to do our best to reduce, to minimize the development of postoperative pulmonary complication. And this is not easy, because there are many factors involved. Not only mechanical ventilation, not only PEEP, not only recruitment maneuvers. There are many, many factors involved. We can modify some of them, but we cannot modify most of them. But one of the most important ones is what we do with our anesthesia machine. How we put the settings, how we put the PEEP, how we put the FiO2, how we put the respiratory rate, how we put the tidal volume. And this is probably one of the most important factors. As I show you, there are intraoperative factors. Ventilation is one of the most important, but not only this one. Postoperative atelectasis is another really important factor, and this is why we need to discuss this always. How to prevent, how to treat intraoperative atelectasis to avoid or at least minimize postoperative atelectasis. So let's start with the recruitment maneuvers. Why we should recruit or run? What is a recruitment maneuver? I think this is the first step, the first thing that we have to think about in order to minimize the impact of mechanical ventilation in lung injury and in postoperative pulmonary complications. So if we believe in papers like this one from Helen Stierna, so I think that we should believe in these papers, these physiological papers. They show us that, well, the prevalence of intraoperative atelectasis is as high as 90% in patients under general anesthesia, under mechanical ventilation. So this is a big number, almost all of the patients, if we trust in these physiological studies, has alveolar collapse, has atelectasis, and we need to do something, because when we induce the patient, when we intubate the patient, we select the tidal volume, we select the FiO2, respiratory rate, but also PEEP, a value of PEEP, 3, 5, 7, and even with this value, they show us that 90% of the patients develop postoperative atelectasis. And as I said, those atelectasis are associated with postoperative pulmonary complications, because they promote lung injury during mechanical ventilation. And why do we have atelectasis in the intraoperative period? Most of them occur during the first 5 to 10 minutes, during the induction, and 5 to 10 minutes. Well, we have different mechanisms. I think probably next lectures will discuss about this, but you all know we have compressive atelectasis. We have an inflammatory response during surgery, not only because of the mechanical ventilation, but by the surgery itself that alters surfactant and promotes atelectasis. We have the absorptive atelectasis when we use really high levels of FiO2. So there are different mechanisms. And the atelectasis by itself promotes one of the main mechanisms of lung injury, which is the atelectrauma, when the alveoli opens and closes its tidal volume or its tidal cycle that we are ventilating the lung. But when we have a big amount of atelectasis, not only the atelectrauma occurs, we have significant reduction in functional lung volume, which means that the gas that we are introducing to our patients each tidal rate, which we believe that is protective, low tidal volume, low driving pressure, maybe is not protective, but to the amount of alveoli that we have opened. And this is why the atelectasis can also promote barotrauma and volutrauma. So if we believe that 90% of our patients have atelectasis, we need to believe that we need to recruit at least 90% of our patients. Well, I have to tell you, and we will hopefully publish this data really soon, that it is not actually true. The number of patients with intraoperative atelectasis, significant intraoperative atelectasis, is much more lower. It's around 50% of our patients, not 90% of our patients. So the first thing that we need to think about is, does my patient have atelectasis? We need to answer this, because if that's not, why to recruit this one? It's an aggressive maneuver, has an impact in the inflammatory response, has an impact in hemodynamics. So the first step is, does my patient have atelectasis? If yes, recruit the lung. If not, do nothing, just maintain the PEEP that you said at the beginning. That's good enough, and you can reassess if the patient has atelectasis during surgeries, in lung surgeries, or in surgeries where the conditions are different, with Trendelenburg, with anti-Trendelenburg, with laparoscopy, robotic, etc., that the lung conditions could change. And how can we answer this? How can we know if a patient has or has not atelectasis? Well, we can do lung ultrasound. Well, this is not real, no, in our daily practice. We can use electrical impedance tomography. Okay, fantastic. How many of you do that in the daily surgery? No, it's not real life nowadays. But we can use quite simple techniques like the pulse oximetry. You know this diagram. You know this diagram because the PaO2 FiO2 diagram is very well known in physiology. Well, it's almost the same with the SpO2. So if we reduce the FiO2 of our patients to 0.21, 0.23, 0.25, why not? Our patients were breathing this before they went to the anesthesia with oxygenation. So if we reduce the FiO2, this is what we call the air test, we can measure the percentage of shunt of our patient. If it's over 10%, which means an SpO2 below 97%, 96, 97%, this patient has shunt, and this shunt is only produced in almost 100% of our surgical patients because intraoperative atelectasis. This is the only reason. If my patient came to the OR with 98, 99, 100% of SpO2, breathing room air, and 5 minutes later, under anesthesia is 24, 23, 25, the only reason, intraoperative atelectasis. So this is the first thing that we need to do, reduce the FiO2 to 0.21, 0.23, 0.25 during a few minutes. Let's see what happens with the SpO2. If it drops, intraoperative atelectasis, so we recruit the lung. And what is a recruitment maneuver? What is the aim of the recruitment maneuver? To restore the functional lung volume, to reverse the alveolar collapse that has been produced during these first minutes after the induction of the anesthesia. Why? Because we want to maintain this lung protective strategy, avoiding atelectrauma, avoiding volutrauma, avoiding barotrauma. So we need to maintain our patient inside this area, which is the lung protective zone. Why? How? Recruiting the lung, setting a level of PEEP, and minimizing the tidal volume or the driving pressure that we are using in our patients. And the only way that we have to restore the functional lung volume, because this is the pressure volume curve and we are moving here with this atelectasis, is increasing the end inspiratory transpulmonary pressure. Obviously, we are not measuring transpulmonary pressure in our surgery patients, in most of our surgery patients. we increase the airway pressure. Until which value? Well, this is another question. This is really difficult to answer because we are not monitoring these patients usually. We are not monitoring any respiratory transpulmonary pressure, but we can tell, I can say you based on physiological studies that 40 centimeters of water of airway pressure is enough for healthy patients, and healthy patients, healthy lungs in our surgical patients. So this is the pressure that we need to achieve, at least 30, 40, if we're not monitoring how the lungs is opening with, let's say, electrical impedance tomography or lung ultrasound, we need to achieve at least 40 centimeters of water. And this is the recruitment maneuver that we propose, a stepwise increase in recruitment maneuver. It's easy to perform. In most of the newer anesthesia machines, we can program this maneuver. It's hemodynamically better tolerated than most of the other recruitment maneuvers that have been proposed, reduces the risk of biotrauma, and it's a really short maneuver. In less than 1.5 minutes, you perform this recruitment maneuver. You can see with this screenshot of an anesthesia machine how we perform this recruitment maneuver. If you're using pressure control ventilation, just use pressure control. If you're using volume control, change to pressure control with a driving pressure of 15 to 20 and a stepwise increasing PEEP. As I said, to achieve this recruitment maneuver. And this is the way to do it. To whom? To those who develop atelectasis. So to those in which we decrease the FiO2 and the SpO2 decreases below 96%. And this is, well, a physiological study that we did using transpulmonary pressure, just trying to know if we were able to find the cutting point, this opening pressure in your patients. And we were not able. Some patients open with 35, others with 38, others with 40, others with 45. Of these patients, laparoscopic surgery patients, we need higher pressures. But, well, using the SpO2, which means recruiting the lung while using 21% of FiO2, the SpO2 helped us to monitor when the lung was opened with the same diagram that we were using. So if we start with 93, and we increase pressure until the SpO2 go over 97%, equal or over 97%. This is the point when we know the lung is already open and we do not need to increase the pressure even more. Just 3 minutes left, so I have to run a little bit. So after we recruit the lung, what to do? And this is very important because if we recruit the lung, well, this is okay. We have restored functional lung volume. We have avoided atelectasis. But if we do not select the PEEP level that our patient needs, if it's too high, we will promote overdistension, we will promote barotrauma, which is a mechanism of lung injury. If it's too low, well, the lung will suffer atelectasis again. So the recruitment maneuver that we have performed just for nothing. So it's really important to select the ideal level of PEEP for our patients. And, well, which one is what we usually do? I don't know for sure. This is Las Vegas study. Probably all of you know this paper, one of the most important epidemiological papers in Europe, showing us what European anesthesiologists do. And as we can see here, well, the PEEP values that were used, in my opinion, were too low. The median of all the patients, 3.5, low-risk patients, 3, high-risk patients, 4.5. Well, but this is my opinion. This is not objective. Maybe those patients need that. The thing is that we didn't know how they select this PEEP, how they do it. Did they try the PEEP? Was a pragmatic PEEP value? Well, we don't know. What we really know is that there is not a magic number. Depends on what? On the patient, on the surgery. There are many factors that can modify the ideal PEEP levels for our patients. Because ideally, we should select the lowest level of PEEP that prevent atelectasis, because it's more dangerous a higher level of PEEP. But we don't know which one is this minimal level of PEEP. 5, 10, 18? In robotic surgery, I don't know. So the only way to know that is to titrate the PEEP level. There are many different ways to titrate, to individualize the PEEP level. We usually use compliance. Why? Because we have compliance in all the anesthesia machines, and all of us know what is compliance, and has been validated in many physiological studies. So this is the PEEP titration. You select the settings, again, that you are going to use during surgery, except for the PEEP level, and you reduce with this stepwise decrease in PEEP level, and monitor compliance. And again, this is a screenshot. This is the PEEP titration. This is how I reduce PEEP in steps of 2 centimeters of water, and this is the compliance. And take a look that the compliance improves because I'm reducing pressures, I'm reducing the already tension, but there is a point here that reduces again the compliance, because at this moment alveolar collapse is appearing again. So this point of highest compliance is the point of PEEP that I should select. This is what we call individualized PEEP, ideal PEEP. There are probably better ways to do it, but not with the monitors that we usually have in the ORs. So this is my last slide. This is my proposal, how we should do in our daily practice, how we should affront these patients. This is what we call the individualized integrative open lung approach. The first thing that I should do is to diagnose this alveolar collapse. As I said, we can use lung ultrasound, we can use lung impedance tomography, but the easiest way is with the air test, just by reducing the FiO2 to 0.21. If the SpO2 is okay, just maintain the PEEP level. This is 50% of our patients, more or less. If it's not, the next step is to check hemodynamic stability. You know that when we perform a recruitment maneuver, we increase intrathoracic pressure, so mean arterial pressure, cardiac output decreases. So we need to optimize the patients in case they need to be optimized before we start the recruitment maneuver. Because if we stop the recruitment maneuver at the middle of the recruitment maneuver, we will not achieve the opening pressure. So we need to optimize hemodynamics. Once we have optimized hemodynamics, individualize recruitment maneuver. How to do that? Well, my recommendation is to use 40 centimeters of water, but if you want to be more accurate, just do the recruitment maneuver with 0.21 FiO2 and monitor the pulse oximetry, and when it's over 97%, I can stop the recruitment maneuver. And once do that, after that is the PEEP titration. Stepwise decreasing PEEP, monitoring compliance. Just looking the trend of the compliance. Compliance will increase, but it will be one moment that drops again because alveolar collapse drops again. So this is the PEEP level that my patient needs. And obviously, in long surgeries, in high-risk surgeries, in dynamic surgeries, when my patients change from trend to anti-trend, from laparotomy to laparoscopy, robotic surgeries, we need to reevaluate the patient. This is not, it's not enough to select the level of PEEP at the beginning of the surgery and do nothing else during the next 3, 4, 5, 6 hours. I need to recheck how is my lung. How to do that? Again, with the air test, reducing the FiO2. We can use compliance, obviously. We had the compliance after the PEEP trial. So if compliance drops, this means, it probably means new alveolar collapse. I said probably because we have the impact of the chest wall compliance. Okay? So this is our proposal of how to manage those surgical patients, and most important, those high-risk surgical patients. So thank you very much.